Hello everyone, my name is Campbell White and I'm a PGY1 acute care pharmacy resident at Cape Fear Valley Medical Center. The title of my research project I will be presenting on is the association of a source-directed therapy sepsis order set with appropriate antibiotic use in patients with sepsis secondary to pneumonia. I have nothing to disclose relevant to the content of this presentation. The objective of my presentation is to discuss influencing factors of empiric antibiotic prescribing for sepsis secondary to pneumonia. I want to give a brief overview of my practice site for contextual purposes. Cape Fear Valley Medical Center is located in Fayetteville, North Carolina. It is a 670-bed community hospital. In 2019, 2,493 adults were diagnosed with sepsis at Cape Fear Valley. Cape Fear Valley Medical Center has Joint Commission disease-specific care certifications for both pneumonia and sepsis. Sepsis is the leading cause of in-hospital death and accounts for 35% of all in-hospital deaths. Many patients are prescribed empiric broad-spectrum antibiotics such as vancomycin, cefepime, and piperacillin tazobactam, regardless of the source of infection. Numerous studies have shown the harm, such as increased risk of acute kidney injury and C. difficile infection associated with prescribing unnecessary broad-spectrum antibiotics. The surviving sepsis guidelines recommend empiric antibiotic selection be based on patient-specific factors and should be influenced by the source of infection, the patient's multi-drug resistant organism risk factors, as well as the patient's immune system status. Cape Fear Valley Medical Center introduced a source-directed antibiotic sepsis order set in November 2018. This order set allows for providers to select the source of infection and provides guideline-recommended treatment options for the selected infection source. The intention behind the source-directed antibiotic sepsis order set is to increase the appropriate empiric antibiotic prescribing while decreasing inappropriate broad-spectrum antibiotic prescribing. The purpose of my research project was to determine if the use of a source-directed antibiotic emission sepsis order set increases appropriate antibiotic prescribing. The primary objective of my study was to compare the percentage of patients who received appropriate antibiotics while using the sepsis order set versus the percentage of patients who received appropriate antibiotics without the use of the sepsis order set in patients with sepsis secondary to pneumonia. Secondary objectives were to assess the general use of the sepsis order set and the impact the sepsis order set had on duration of antibiotic treatment, including discharge antibiotics, as well as adverse events between groups. Adverse events included acute kidney injury, which was defined as an increase in serum creatinine of 0.3 milligrams per deciliter or more within a 48-hour time period. C. difficile infection, defined as a positive PCR test during admission and 30 days after discharge, and documented adverse drug reactions. This was a single-center retrospective cohort study. A chart review was performed on all eligible patients admitted between November 1, 2019 and January 31, 2020. Patients had to be discharged for at least 30 days before a chart review could be performed due to the secondary endpoint involving C. difficile occurrence. Patients were included in the study if they were an adult admitted to Cape Fear Valley Medical Center through Cape Fear Valley Medical Center's emergency department. Patients were excluded if there was uncertainty regarding the source of infection or possibility of multiple sources of infection, as this would influence antibiotic choice as well as antibiotic duration. Patients were also excluded if they were on hemodialysis or if the patient was pregnant. I wanted to provide a visual of the study design. Patients were identified based on an admission diagnosis of sepsis secondary to pneumonia. A chart review was then performed to first determine if the patient met inclusion and exclusion criteria. If the patient was eligible for the study, we then determined if the sepsis order set was utilized. From there, we determined if appropriate antibiotics were prescribed or not. We defined appropriate antibiotics as antibiotics compliant with the 2019 IDSA-ATS guidelines for community-acquired pneumonia, and based on patient allergies, multi-drug resistant organism risk factors, and immune system status. The chart on the right side of the screen contains multi-drug resistant organism and immunocompromising conditions compiled from the 2007 and 2019 IDSA community-acquired pneumonia guidelines. If a patient were to possess a condition listed in this chart, an antibiotic regimen covering MRSA and/or Pseudomonas was considered appropriate. On the other hand, an antibiotic regimen containing MRSA and/or Pseudomonas coverage was considered inappropriate if a patient did not possess a condition on this chart. Due to the unknown impact of the source-directed sepsis order set on effect size, no formal sample size calculation was conducted. All patients submitted during the study timeframe were reviewed. All outcomes were analyzed using descriptive statistics for reasons to be discussed later, and JMP14 Pro software was used to perform the statistical analysis. 125 patients were identified based on an admission diagnosis of sepsis secondary to pneumonia. 78 patients met inclusion and exclusion criteria. The main reasons for exclusion were patients with multiple sources of infection and patients who were in-stage renal disease on hemodialysis. The average age of patients included in this study was 63.8 years. The majority of patients were male at 56.4%. Over 80% of patients had a QSOFA score of 0 or 1, and 70% had 2 or 3 SERC criteria. 33 patients had at least one multi-drug resistant organism risk factor, with the most common risk factor being IV antibiotic recipient in the previous 90 days. 9 patients had an immune-compromising condition, and 8 patients had positive blood cultures. Only 1 patient in the study received antibiotics ordered with the sepsis order set. Because of this, it was decided to perform descriptive statistics rather than inferential statistics. 60.3% of patients received appropriate antibiotics, and only 21.8% of patients received 7 days or less of antibiotics. 12 patients in the study experienced an adverse drug event, with 11 of those events being an acute kidney injury and 1 event being a C. difficile infection. Because one of my study groups had only 1 patient, we were unable to determine if a source-directed antibiotic sepsis order set was associated with increased appropriate antibiotic prescribing, decreased durations of therapy, or decreased adverse drug events. We discovered many patients received antibiotics beyond guideline recommendations of durations of therapy. Numerous patients were discharged with 7+ days of antibiotics. We were aware of the low use of order sets prior to the initiation of this study. However, we felt with education on the use of the order sets, which was being done at the time, there would be more orders prescribed using order sets, so we decided to proceed with the study. One barrier to the utility of the source-directed antibiotic sepsis order set is it is embedded in an extensive sepsis order set with many checkboxes for nursing, diet, lab, and other orders. The order set may simply be too time-consuming for providers. There could also be a false understanding of appropriate empiric antibiotics for sepsis among providers, as well as an unawareness of the harms of unnecessary broad-spectrum antibiotic use. There were several limitations with our study. One limitation being Cape Fear Valley Medical Center launched Epic software just 6 months before the initiation of the study. Providers may have simply not have known the order set exists or how to operate or access the order set. Second, all medical history was obtained through Cape Fear Valley Medical Center records only. A patient could have received IV antibiotics in the previous 90 days at another healthcare facility or received a diagnosis of C. difficile infection, and we would not have known. Lastly, the source-directed antibiotic sepsis order set does not prompt providers to evaluate multi-drug resistant organism risk factors or immunocompromising conditions. The antibiotics listed in the order set may not be appropriate for patients at an increased risk of multi-drug resistant organism infection. As for any order set, clinical judgment should be applied. I would like to take this time to acknowledge and thank my research team, Dr. Sharina Tart, Dr. Austin Everett, and Dr. Michael Crawford. We are going to finish up with a self-assessment question. Which of the following patients diagnosed with sepsis secondary to pneumonia has an indication for broad-spectrum antibiotics? And the answer is C, due to her recent IV antibiotic exposure. Here are my references. Thanks for listening.